Hello, everyone. Thank you for joining me. My name is Carrie Gray, and I'm a clinical outcomes coordinator in the Department of Quality and Safety at MedStar Georgetown University Hospital. And I am here today to present to you our abstract and poster submission for this conference, Steering the Ship on Opioid Safety, Reducing Opioid-Induced Oversedation Events in Hospitalized Patients. And here's a snapshot of our poster. A little bit of background. JCAHO updated their pain management standards in 2018 in response to the opioid epidemic. MedStar Georgetown asked Pain and Sedation Committee to provide leadership and oversight regarding our pain management practices and to ensure safe opioid prescribing. The committee undertook a gap analysis at that time to review current practices. One of the findings was that we have a concern with opioid-related oversedation. Around this time, a Narcan Debrief was developed by committee members to help identify contributing factors and raise awareness for our hospital staff and clinicians. This real-time event review was completed by nurses, providers, and pharmacists. Along with that, the quality department does deep dive chart reviews on every naloxone administration. And opioid-related cases are reviewed robustly by various committees, as well as by our Director of Acute Pain Service. There were many root causes identified. Here are some highlights. One of the most significant findings was that 70% of these patients had received both opioids and other sedating medications leading up to the Narcan event. Medications include drugs such as Neurontin, antiemetics, sleeping medications, and benzodiazepines. It was noted that patients were being administered these medications together or close together, which is called stacking. Also, within this population, it was noted that many patients had developed acute kidney injury after admission, had either a history of sleep apnea or were high risk for it, and also that patients had a history of chronic pain. Overall, there was also noted to be an underutilization of our acute pain service. We had many interventions that came out of our findings. Here are some highlights. There was a development of interactive pain management boards for clinicians to use, including one for Narcan. We have had multidisciplinary education sessions where we can deep dive into complex cases, review lessons learned, and promote best practice. We elevated a concern to the system level, and they created an enhancement of our electronic medical record, a pharmacist alert for increased creatinine for patients who are taking gabapentin. We have an expansion of use of pulse oximetry on multiple units. Finally, we also increased the number of acute pain service consultations by 213% over the last 4 years, as well as increasing the use of regional anesthesia. What was the outcome? Well, we have had a 60% reduction in opioid-related oversedation cases over the last 4 years. Our takeaways: identify your patient populations at risk and the contributing factors to help you with developing interventions. Utilize your technology for decision support. Use of a pain service early on can help prevent opioid oversedation. Finally, education and raising awareness with your clinicians and frontline clinicians can really help with changing culture and sustaining improvements. Thank you.